Thank you, Greg. Are we ready to be astounding?
Yes.
No, we, in the conversation sort of leading up to today, a lot of excitement about all of these panels. And we thought this would be a good panel to end with because it's a demonstration of a lot of the issues and activities that have been discussed today. Let me just give you some context for how this panel emerged and what Greg was discussing and what we've been learning about it at IC Squared. So back in the fall, some of us at IC Squared participated in a event that the Dell Medical School had. Minnie Cologne, who was earlier here, sort of moderating the social determinants of health panel, her team at Dell Med and the Health Factor, or Factor Health Group, held an event called Healthscape, which is essentially this idea of how healthcare, health access, health literacy is spilling outside of the four walls of the clinic. And so what are the ways in which community-based organizations, what we call anchor institutions, are sort of responding to a lot of these social determinants of health that we have been talking about here today. One of our board members at IC Squared, I saw him here earlier today, I'm not quite sure if I don't see him in the room currently, introduced us to, he also sits on the board of the University of South Carolina School of Medicine. And that's how we met Megan and learned about a lot of interesting work that they're doing in their School of Medicine. But one of the interesting things, and Megan's going to be talking about this today, is the role that libraries are beginning to play on the front lines in terms of serving their communities and serving those community needs. What we've learned from Megan and others like her is that social determinants of health are walking through the door every day. People in need of food, people in need of housing stability, people sort of addressing substance abuse and drug use. And so it opened our eyes up to a whole new arena of what's happening in the healthcare space that we simply were not aware of. And that is the degree to which more and more of our anchor institutions, public service institutions are responding to these social determinants of health in ways that are quite creative, but also episodic and improvisational. And how do we begin to be more intentional, more strategic, more purposeful in terms of building sustainable infrastructure to support that work? Another of our board members is involved in developing affordable housing here in Austin. He began introducing us to a variety of people, which is how we met Jennifer, who's based in Dallas. And she'll be talking about some of the work that her and her team are doing as it relates to delivering healthcare services via the affordable housing properties that they're developing. And then with Angela, she was also involved in a Healthscape event, her team out of the School of Nursing here at the University of Texas at Austin, and the work that they're doing with faith-based organizations, specifically African-American churches, and delivering vaccines, delivering mental health counseling. And then Abena also with the St. Davis Foundation, leading some really interesting work, sort of piloting some of these ideas in terms of libraries being on the front lines, delivering, for example, mental health services. And so we see this idea of well-being hubs and the ways in which healthcare, health literacy, health access are emerging as really interesting, really creative. And as you think about a lot of what we've heard today, right, the increasing demand for services is sort of overwhelming our healthcare system, overwhelming our healthcare professionals. And it's, I think, a really interesting opportunity to see how these community-based anchor institutions may be a resource, right, in terms of helping to sort of mitigate some of these pressures and beginning to expand how we think about access, where people are getting care, and how care is being transformed as a result. It has implications for how care is being delivered, implications for who's delivering that care, and so it's a way of sort of rethinking, right, how we might understand the future of health equity in a number of interesting ways. So that's a little bit of context. And I'd like to open it up and maybe have each of you talk a little bit about your specific domains, right? Housing, affordable housing, libraries, faith-based organizations. If each of you could talk a bit about what you're seeing in terms of community needs, what kinds of health challenges are you facing, and maybe talk a bit about how your respective organizations are responding to those challenges in ways that I think many people would be amazed by.
Okay, we're all looking around. Hey, I'm Megan. I am the person from South Carolina. So just as a little bit of background, our population's about 5.2 million. I know we're a lot smaller than y'all. You can go from the furthest drive for our state is from the high corner of Oconee, Appalachia, all the way down to Hilton Head, which y'all probably do know, down in the Low Country, or Jasper. And that's about 5 hours or so, 5-6 hours, depending. So I know geography-wise, we are much smaller than y'all. Our population is almost 70% white, about a little over 26% black. Our Hispanic population is growing, but just demographically, we are different in many ways, but many of the challenges that we face are really similar, as I've learned in talking with Craig and everyone here at IC2, and also with Abena as we connected through some of our library work. So South Carolina, the state motto is thank God for Mississippi, because when it comes to all the lists, we're 49 and they're 50. Or we're number 2 and they're number 1 when it comes to that. So it's almost, in many ways, as we talk about the challenges, I mean, I make the flippant joke, but we have a lot of challenges because you know how systematically everything comes together. What's really rising to the top in a lot of areas, particularly is mental health, rural mental health, particularly through the COVID pandemic. There's a huge opioid crisis in many of our areas, substance use disorders, et cetera. Also, maternal and infant child health. The latest infant mortality numbers came out last week in my state, and Black infant deaths are up 40% from 2017 to 2021. 40%. This is 2.4 times higher than the white population. Overall, so talking about disaggregation of data, overall we're up 12%, not good, but our Black population is up 40%. Our death rate for Black moms is 67% higher than our white moms. There's a lot going on there systemically, right? So in terms of the challenges we're addressing, a lot of these things come from, where you're able to access care. We have 14 counties, not just without labor and delivery, because those mostly closed, but not without an OBGYN at all, like in the county. So trying to really look at what needs are. We have those, and then we have those social needs. So my center actually started in 2017. We're legislatively funded. I think that's an important point to make. Our legislature created us as a center of excellence within the School of Medicine to work statewide. So we work with basically every health system in the state and every university in the state. It's not just a University of South Carolina program. And we do a lot of research and development. We do workforce training and other areas. We work within the clinic walls for changing of healthcare delivery, but also what I'm here to talk about mostly is that community connections. So a few of our strategies do include telehealth, also really working a lot with our Department of Health and Human Services to expand mobile health units to get folks out to communities. That's where it kind of goes. And then also through libraries, where we're really able to meet people where they are, where people are already going. Nationally, 95% of folks live within, with access to public library services. You can't say that for healthcare. Also, 37% of folks going to libraries are already going looking for health information. And also when you're there, you can strike up a conversation, right? So South Carolina really was on the forefront of some of this work. The first full-time social worker in South Carolina, first full-time social worker hired by a library was actually in South Carolina on a project I was a part of from another nonprofit, and I met her and I realized, wow, libraries are the place to be, because that's where everybody is. So instead of how do we get people to come in, how do we get them to come here, how do we solve this transportation issue, it's like, what if we go where they are and we have folks that people are comfortable speaking with and doing that. So I know we have more time and everyone has more things to answer, but we work with 9 library systems across our state. We have about 46 counties, so that encompasses 9 counties, basically, to have a health liaison, a social worker, a community health worker. This isn't profession specific. It's getting the job done. It's not a certain credential, but you do need some sort of training. But to meet the social needs of folks coming into the libraries, and to that end, what we're really seeing that's leading to some of these health outcomes, it's housing. It's they come in for housing, food. They come in for food assistance, and then applications for like Medicare and for healthcare. But we have folks based at the library. They have a healthcare partner, and again, it can be a health system. It can be an FQHC. It could be a rural health clinic. It could be another type of local provider. In one case, it's the free clinic. So again, it's an open model. But they have to have a healthcare partner to be able to make those connections and those referrals. And then we can talk more about some of those impacts later. But with us as a legislatively funded center, we were able to develop basically an RFP to work with libraries. So we provide the technical assistance, we provide the funding, we provide some sustainability planning and other areas, and also a learning collaborative so they can learn from each other. So as we were talking earlier, there's a lot of great examples of one-offs. We're trying to build this into more of a systemic approach in the state.
Jennifer?
Thank you. So what we do at Veritas Impact Partners is serve working families living paycheck to paycheck. we partner with apartment owners providing naturally occurring workforce housing. And as you know, those are just not the brand new shiny apartments, but the apartments built in the 80s. And we all know where they are, right next to the check cashing place and probably close to a Walmart and some other not great places. And so apartment owners were like, hey, so we can't do granite countertops, we can't do dog parks, and 50% of our residents leave all the time, and we have all these other issues. What if we actually started providing real support resources for them? And that's kind of the foundational principle of where Veritas Impact Partners comes from. So we are the social impact ninjas designed to be in the living room of working families. That is our office, the living room. Because what we know for sure is this, and no, we're not in rural areas. We're in Dallas and Austin and Houston and Atlanta. We're exactly on Metropolis Drive, you know. So who lives on Metropolis Drive? They've got a 45-minute commute, a 30-minute lunch break, and limited paid time off. They can't access buildings open to 8 to 5 with long lines, qualifications that they never qualify for, and they probably don't speak English. So with that at the center, that's who we serve, a diverse population, and we look to bring impact for health, education, and economic development. And our key word is access. And as we've talked about, there's many different ways to look at access, but when it comes in the health realm, it's two questions for us and for our residents. How do I get to a doctor when I need one, and how do I pay for that care? 22% of the working population is uninsured, and a greater percent is underinsured. And medical debt is usually 80% of a family's total debt load. So, as residents of these apartments, they get 100% free telehealth. We've partnered with the nation's largest provider of telehealth services, and 24/7, 365 days a year, you can access for you and anyone else living in your apartment free primary care services in 25 languages. And what's been able to happen from that is we now know that we are impacting families at a rate of $492 a month saved because they don't have those extra costs. We also know that the top 3 telehealth calls on our properties match the top 3 avoidable ER visits in every single one of our communities, saving more than $7,000 a day to the community. But more than anything else, what we know is the expanded bandwidth that comes back to the working family. Because that's really what we're talking today about, access or bandwidth. When you have to pray over a crib in the dark of night, please, baby, breathe, because you don't have $85. $85, not $2,000, $85 to make a copay and get the prescription you need so your baby can breathe, because you're 5 days away from payday with an overdrawn bank account. That's what we're talking about with access for working families. And so we are excited and passionate to do this work. And in less than 3 years, we now have 5,371 residents accessing telehealth. Nationally, there are 3 million telehealth users, and only 7 to 10% actually activate that. On our properties, we have a rate of 28% activation. It shows that it's about the access point. And once we deliver that in trusted ways, they're able to take that and enroll that as a benefit for their life.
Angela?
Hello, everyone. I work for the UT School of Nursing on the AMEN program, which stands for African American mental health wellness program. And what that consists of is that before COVID, we were taking UT students into African American churches doing health assessments, something that wasn't done. And what they were doing was helping the congregants get their numbers. So they were letting them see how high their blood pressure was, their sugar, the weight, and the students was able to work with these African Americans, and the African Americans was able to be more comfortable working with medical students. And it became a huge success. So we moved it up to caseworking. So those members of the church that had high numbers or some issues, these students would then link up with them and contact them once a week to say, how's it going, da-da-da. And so it became very comfortable. In the beginning, it was a little sketchy because the congregants was like, no, I don't want nobody to know my numbers. No, I don't want you to be doing this. I don't want you doing that. What you want to know that for? But we kept it consistent. We kept it consistent. And then they became comfortable. They would start asking me, Angela, when the nurses coming? I want to see the nurses. I want to see if my numbers were right. And so it became a huge success. But then COVID hit. So churches dispersed. Nobody was in churches. So then what do you do? So what we did is we went to calling. We had surveys where we would call to find out, do you have your medicine? Are you okay? Is somebody with you? And all these questions. But what we found out through these surveys was that majority of them were okay, but just lonely. And so when I was calling, trying to go through the survey, they didn't want to go through those questions. They wanted to talk. Because we realized then that a lot of them didn't have loved ones that was there because everybody was scared. Everybody was scared to give their mama COVID. Everybody was scared to give this person COVID. So everybody was dispersed into their own house. So a lot of our members were lonely. And so what we did is that we would go through this survey, and when there was a red flag to say that somebody had some really problems, we can tell that something was not going on, we would then pass that on to the pastors of that church and to the UT nurses so that we can kind of double up. We wanted to double up to make sure that person was okay. And that was a huge success. They felt that they were heard. They felt that somebody was going to check on them, and they knew that we were going to be there. So that was a huge success. And then the vaccination clinic came in. I helped lead what they call VMOS, Vaccination Mobile Clinic. So we started doing that at the churches because, as you heard over the news, they were saying African Americans are not getting the shots. They're not getting the shots. So we took it to the churches. And so we did lines where we had the nurses. I was taking down the cards. I had the names. And we had lines. We did hundreds at churches, hundreds. We were doing it. I know I worked at least 10 churches. And one of the biggest one was Mount Sinai, and we had 300 to drive through there to get their shots. And so we pushed hard to do this. My church was one of the first churches, hallelujah. And so we did that because we wanted to see how it was going to work. Inside the church, the nurses was in there doing the shots, setting them up. Outside the churches, the nurses had booths. When cars drove through, you get your shot. We had a group in the front that was checking names, getting the cards, and it worked. And so we was able to knock it out. And then the next move was going to the homes for those who could not come out and get their shots. That became very interesting because it was me and a nurse, me and two nurses. We would go to the house, and then we was finding out more needs that they had. Some need medical equipment. Some need food. So then we was like, okay, we need to connect. So I was able to connect with Age of Central Texas, who gave free medical supplies. And it was like big. So I was calling them saying, hey, this lady needs a wheelchair. Hey, this lady needs some bed padding. Hey, and they was like, we got it, we got it. And so then we was able to make that connection. Then it was food. Then we was able to get to the pantries. We was able to give them information, but we were boots on the ground. And, you know, until you're on the ground, then you know the need. Because one time we decided, I run a community garden in the East Austin, and we had a large harvest of collard greens. So we were like, we're going to cook these greens, make some cornbread with the members, and we're going to go out and feed the homeless. Well, what we learned is that they didn't want that. They wanted water. We didn't know. We had food, so because that's what we thought she wanted. So we was driving to them, we got food. They was like, okay, this is fine, but where's the water? And we was like, what? We didn't realize the public waters was cut off. So we didn't realize that, but until we hit the ground, then we realized it. So then we had to go back and we took water. So we learned as we was going through this process of what we were doing. Another thing that Amen did was that through this COVID, we realized the ministers, especially the African-American ministers, needed to be debriefed. Because in the African-American community, the pastors are their counselors. They might not go to a psychiatrist, but they're going to their pastor. Well, the pastors used to hearing horror stories once a month or once every da-da-da. They were hearing them daily. They were hearing them weekly. They were burying members every week. They didn't have a weekend off. They were burying members every weekend, so they didn't have time to debrief or to even grieve. So then we had to call in the ministers with some mental health people and try to debrief them and try to get them in the best place. So that's when community health workers stepped up. We started being a resource for the ministers to let them know, listen, when you need this, we got you. When you need that, and that helped to ease up a lot of what the ministers was dealing with, because they were trying to find food for their members. They were trying to find this and that. They were trying to cover families. And then the ministers were losing family members, and they were grieving. And so now you have a grieving pastor who's getting hit every week. And so we tried to be that soft in between, where we was helping them with resources. We was helping them with getting connected to NAMI, who's free. You know, getting connected to counseling that was free and bringing it to the church. You know, my pastor set up a mental health team at the church because a lot of churches didn't know how to handle mental health. You know, we all know that member that kind of acting a little off, but we just kind of ignore her. But until she do something really bad, and then we all are running. So the pastors started to be proactive, and they started training certain members to be active with these people in the church who were suffering. And what we did is just kind of sat with them in church and kind of be that comfort and buffer to see what's going on. And then we would take them to the side later and kind of do a debriefing and find out what's going on. And so these are the things that we're doing in the churches. These are the things that we're doing in the faith-based community. I'm up under St. John Regular Association, which houses 88 African-American churches all through Austin, through Bastrop, Elgin, Manor. And so there's a lot of churches. And so we worked with mostly those churches, but we just made sure that we had good resources and we stayed in touch so that they know that they are heard and that we can help them. Thank you.
Abner, could you talk a bit about the pilot program that you're doing through St. David's Foundation, the Libraries for Health? What was sort of the motivation for that, and have you just sort of designed that program, and what else can you share about what you're looking to learn from in terms of how libraries may be leveraged to deliver some of these health services?
Thank you, Craig. So St. David's Foundation, in our role as being affiliated with St. David's Healthcare and receiving funding from St. David's Healthcare, we also, in partnership with other health systems and health departments, conduct the community health needs assessment every 3 years. And what we've heard consistently is the mental health gap in these communities. That comes up hands down every time. And also in my role as a senior program officer working in the rural communities outside Austin, that also came out in my dialogue every time. And so we had to think about addressing these challenges in a different way. We know that these communities are mental health shortage areas. Lillian, you know that. And so what are some of the ways that we can reimagine the delivery of mental wellness services within communities so that people can start receiving some supports before their condition escalates? And so in dialogue with community members and also thinking about libraries as social infrastructures, places where people feel welcome, places where people of all socioeconomic backgrounds visit, we started having dialogues with the libraries to find out, what are you seeing? What are you hearing? So the libraries help inform this process of the Libraries for Health initiative, which embeds a peer specialist, a mental health peer specialist within the library setting to provide wellness supports to adult patrons that visit. So it's a 3-year pilot that Craig alluded to because we want to see if this works. So our partner in this work is RAND. So RAND is going to evaluate the initiative, which is going on in 10 library sites here in Central Texas, to see what capacity building approaches works, what can we learn from this, how can this information that we are learning be disseminated not only to the library sectors, but also to mental health systems and also policy makers. Our mental health provider is Via Hope, and so they hire, train, and places the peer specialists in the libraries. So this, what we are trying to do is something that has been going on globally called task sharing, where you use a lay person, a lay individual, train them in the particular health or social services, and then they, in turn, living in the community, approach other community members, and then talk with them about the issues that they are facing. When you look at the access to mental wellness services or mental health services here in Central Texas, in our 5 counties, only Travis County has a ratio, a resident to counselor ratio that is lower than the national average. The national average is 1 mental health provider to 350 residents. Travis County has 1 to 320, Bastrop County 1 to 1580. We all know what COVID did. People are still experiencing the anxiety, the depression, and then that's compounded by the barriers, transportation. And so we need to think about reimagining how mental health and other services can be delivered in naturally trusted or caring spaces. We know that the old ways are not working, so we have to push ourselves to think about new ways of delivering services to our priority populations.
One of the things that I think each of you have touched upon in your respective comments and reflections, and this has come up throughout the day and some of the other panels as well, is that there are these systemic barriers, right, to people accessing care, and they're multiple, right, in terms of how they manifest themselves. But I think what struck us about what we've learned from our conversations with you and learning more and more about how these well-being hubs that are community-based, community-anchored, are able to sort of fill in some of these gaps that you're each alluding to is this issue of trust. And I'm wondering to what extent could you maybe expound upon how you think trust in some ways is sort of transformational in terms of your relationship to the people that you're serving, the needs that you're meeting, and the impacts that you're possibly having.
I made the comment about data before, and I think that sort of the qualifications and the data speaks to trust. So there are 3 key things that we do, and it is foundational. So first of all, you have to speak like and look like the people you serve, period, end of sentence. Doesn't work to have a phone translator. It doesn't work to have a highlighted card that you turn around on a clipboard. You have to speak like and look like the people you serve. And when you're creating community hubs, like all of us have talked about, you're standing in the living rooms and the kitchens and the doorways. And so there's automatically an even playing field. But beyond that, for us at Veritas, it's the release of qualifications. Imagine that, to stand at someone's doorway and say, Sarah, I'm here to help you get those free doctor visits. And they're like, yeah, I saw the email about that, but I wasn't really thinking it was real. And then you say, no, it really is real. And they look at you and you say, why am I getting this? Who's doing this? And I never ask Sarah how old she is, how much money she makes, what ethnicity, race, or anything else. I just look at her and I say, it's a gift. It's a gift for living here. And it physically changes people and creates even more access points for all of those other social determinants of health or well-being or all of the other things we want to create in community. If we could challenge ourselves, innovate hard and deep to let go of qualifications. How do we just trust and know that these are the services needed?
Jennifer, I'm going to continue with where you left off. Trust is so important, and sometimes funders do not take the time to realize the importance of building relationships, which is the foundation before trust can be built. Well, and some of these communities that we work in have been harmed by all of us sitting in this room. We go and then we extract information from them, and then our study ends, our program ends, and we don't go back. And so those communities are already not trusting us. So we have to start from a place of getting to know them, getting to know their culture, their history, their families, what's going on in their community, and not to use that extractive mindset in the work. So in the field of philanthropy, we have this thing called trust-based philanthropy, where there are principles where we are learning on how donors, nonprofits, communities can work together so that we can shift the power imbalance as well as decision-making. How do we center community members? Those individuals that are faced with these disparities, how do we center them in our conversation? How do we create a table with chairs, not foldable chairs, but permanent chairs for these communities or individuals to feel comfortable coming back to sit at the table?
Yeah, I would love to echo on what you were just saying. So, as I said before, I'm based in an academic medical center. I mean, how more, ivory tower medicine, we're coming in, oh, this is what's wrong with you, you need to do this. Oh, why didn't you take your medication? You are the cause of your problem. Some of that attitude, just colloquially. So really being cognizant of it, I come to the medical center, my background's in public health, which has really, I think, helped that. So we've tried to address this in a few ways in the Connecting Communities work. One is with the libraries program that we did develop. We were approached by the second library to have a social worker for funding. And because, again, the legislature entrusts us to help do some of the work, which is the main point. It isn't the University of South Carolina, CRPH, going into the community and doing the work. We're not hiring people, we're not putting them in. We are working with already established trusted groups, the local library, the local FQHC, the local free clinic. So folks who are already there, who know what they're doing, who know what the deep problems are. With our libraries and our well-being hub, it's from the academic side, you could say, a true researcher academic going for an NIH grant would not fund the program that we do because we allow each community to choose that model. We're not saying this is the exact model that we're going to do. You have to hire this person, they work these hours, they do just this narrow disease because we got to get the data. Only A1Cs, it doesn't matter if someone comes in with mental health, it doesn't matter who's coming in. So from that model, again, overgeneralizing it somewhat, but saying we need a health liaison based at the library because it was important for us to say that because we do have a history in our state of maybe the medical centers just coming in doing, oh, we've done our community benefit and going. So we wanted to make sure the library was a full partner, and directing who gets the money was a good way to do that. But being able to have a social worker, a community health worker, and all the other ways. So that I really think pinpoints the other point to me for trust. We talk a lot about how we build trust with communities, how do we get them to trust us? How do we get them to trust us? Well, I think the first step in that is that we trust them and we show that. So again, in talking to the library, okay, a social worker versus a community health worker, or you say we only need someone part-time or full-time, okay, we'll try it. We will have the rigorous evaluation of what you want to do for that impact, but it's seeing what can do that. So I think that really builds on what you were saying. It's a two-way street. So many times I'm in the academic rooms, it's like, well, they just don't trust us, or in public health, or how do we build trust? We have to trust the people we're working with and show them that, and sometimes that means giving up a little bit of control, which can be very difficult when you're in an academic center or you're answering to the state legislature. It's helpful when we have representatives who know what we're doing and knowing in their community, and they're hearing from their community members that they like it, so that's how we work with the legislative side. But anyway, there's just that two-way street, I think, is critical.
And Megan, you mentioned flexibility, which is very important. You can't go to a community or do a program and be rigid. So with Libraries for Health, the funding that was given to libraries was flexible funding because each library is different. Yep. Some of them have a veteran population, some of them have seniors, some of them have homeless, bilingual. And so with the implementation plans that they all created, it had to suit what they saw every day in the library setting.
Well, thank you each, and we wanted you just to hear some of these stories because we've been struck by them, and as I mentioned earlier, they've sort of opened our eyes up to whole new frontiers of the kinds of questions that we're asking and what's really happening on the ground as these community-based anchor institutions are confronting these issues. This isn't theoretical. This isn't speculative. This is happening, right? And we've talked to you, of course, and certainly many of your colleagues. And so this is happening, and we just wanted to spotlight this work. If you have ideas related to think, related to do, or to funding, please share them as it relates to the work that you're hearing about here, and how we may be able to be more strategic, more focused, and certainly more purposeful in terms of expanding the capacity of these community-based institutions to sort of respond to the health crises that we certainly know exist in this country. We could go on, as we could with all of the other panels, but we want to give you an opportunity if you have questions or thoughts here before we wrap. You have one. Yeah.
First, they delivered, didn't they?
Jennifer, I just had a quick question. The housing properties, do they have free Wi-Fi or using that telehealth? I was just curious how the internet connection was and if it was inside their, did they have access to it inside their living rooms, or did they actually go down to the common area in a private space?
Yeah, thank you. Great question. So just a little bit of back context. So I started Veritas Impact Partners August 1st, 2020. So in the midst of lockdowns. And I can honestly say, after serving nearly 10,000 households in the realm where I am, working families living paycheck to paycheck, this is unsubsidized families, there was no digital problem. So no, none of that. They all had their own Wi-Fi that they pay for. They may have been on different programs, or we would connect. And as long as you keep it smartphone based, you were fine. When it becomes into an educational realm and you start requiring multiple kids to be online at multiple times and multiple devices, well then that is a challenge. But smartphone based, it's not fast Wi-Fi, definitely not fast Wi-Fi, but Wi-Fi and smartphone based. The bigger problem is the language. So many of the tools that we have are English only. And so making sure that things are bilingual.
Hello. So today, as we're talking about underserved communities and populations, nothing has been mentioned about veterans and military, and they all are also an underserved population. Although there is access to VA that's very complicated, as many of you know. And then veterans in rural communities don't have access as well. The statistics for suicide for veterans is 1.5 times the general population. For women veterans, it's 2.5 times. Significant problem. So just wondering what your thoughts are around that population and how we can better serve them.
So with the Libraries for Health projects, some of the libraries identified the veteran population as a population that they wanted to work with. And so I know that like Jarrell and Smithville and some of those other smaller libraries have their peer specialists trained to work with veterans.
I can speak loud though, but so I'm fascinated by this whole thing that you guys are talking about with the libraries, because a lot of what I work in now, they do school-based health clinics. So I really love that, meeting people where they're at. My question is, how did you get that started, and how did you, I guess, get that core to make sure that it happens? Because that's a shift, I think. And yeah, that's just my question. How did it happen?
I'd say it's a little bit of the mix of the personal with the professional. So back with the implementation of the Affordable Care Act, there were some donor-advised funds into the county. Our capital is in Richland County, so where Columbia is based. And at the time, I was working at our state's Public Health Institute, so there was a grant that went to the School of Journalism, the School of Public Health, that the Public Health Institute had grown out of, and with the Richland County Library, and I was the subject matter expert. It was under that grant that the social worker I mentioned was hired in terms of navigation to help people get onto the health insurance exchange. And actually, we have this amazing photo of the last day. I think it was 2014. I forget. It's gone together so much. But the last day of open enrollment, for that first open enrollment period, and the line was out the door, and she tweeted it out, and the Today Show kicked off with it. And it was that experience and being some of the focus groups for the messaging, while the library and all that I personally, from my public health siloed background, with all the different systemic things that we have, the libraries were never shown on there. We talked about the trash collectors being public health workers, we're sanitation, but not librarians, and folks working in the library. So that's how that came together, and I always wanted to get back to that. I live in that county. I see how it's going. Hit March 16th, 2020, I start the job at the University of South Carolina, the first day of the shutdown. But one of the things our center does is we have some funds to be able to fund pilot programs and innovative programs. In that pile that had already been submitted around the time I was hired was from Union County, a rural library, and they had worked with the State Blue Cross Blue Shield Foundation and our state's Office of Rural Health, and they'd had a social work intern, and they wanted to hire a full-time social worker. So that's where I said they had approached us. So between them having that application, me and my background coming together, we were there and we were like, yes, this would be great, but why one? Why one? Why one? And we were, fortunately, this doesn't always happen, we were in the opportunity where we could fund it more systemically as a program around that. The community connection side for the center was new, so there was a pot of money that wasn't already obligated. So we were able to go into that. So, and then also in the meantime, nationally, social workers and libraries, community health workers and libraries. Philadelphia has co-located a library and a clinic for years. Yuma County, Arizona has been doing it for years. National Network of Libraries of Medicine has been doing digital health literacy and other things for years. So it's almost like, when the opportunity and the timing, some of that little bit of magic that 5 years earlier, maybe not, but right then it happened. So it's really, I think, a combination of everything coming together at the right time and then broader with the national movement. And it was through those connections that we had actually connected and started talking, because I heard about Abina's program, and it's like, tell me more. So for that, sorry if that was a little long.
No, I was just going to echo the same thing, and we asked the same question of Abina, of Megan, and certainly the others here as well. And we've talked to librarians across the country, And at least partly how I might respond to that, right, is the question of how it happened. It happened because it had to happen, and it happened because those in need basically made it happen. When you don't have access to services, when you don't have access to the things that you need, you find a way to get them. And for many of them, they've seen a library as a resource, as an opportunity for that. And because of that sort of perspective and that viewpoint and that experience, they've compelled, from my perspective, right, libraries to be much more responsive. And so now libraries are integrating social workers, they're integrating mental health, they're integrating other health services, in part, right, because the demand is there and the expectation is there. And so in some ways sort of speaks to how grassroots is sort of transforming how these organizations are working. What we're learning, right, is the need to better communicate this, right, and to better create greater public awareness of how each of these respective institutions and well-being hubs are functioning, and why we need to begin building models and policies and interventions to help sustain this work in a much more, high-capacity way. I think we are. We're going to let you ask a question because you didn't get to ask your question in the last session. So this, yeah.
I'm just going to share because this relates to the library. Before the pandemic, I was hired to do community engagement work for Austin Public Health, and I go to the library quite a bit, and I saw there was all these people who needed help at the libraries, and and then we're like, okay. The staff are very busy, and they are not trained to provide these services. Why don't we at Austin Public Health bring our CHW to the library? So we pilot a program. It was like we call it a traveling CHW program, and we just set up shop at one of the library, Little Walnut Creek Library in North Austin, and it was very simple. It's just a table. It has a cloth, and they say, come and ask a community health worker, anything you need. So there was all these people who came, and they have every need that you could think of, particularly MAP enrollment, food, transportation, and I think it was really a good program for us because we get to bring the services to the people and also help out the staff at the library. And then when the pandemic hit, we had to pivot, and because we have that relationship with the library, we said, why don't we approach the library to open up clinic for us to vaccinate the community? And because we have developed that relationship with the library and the community, at first they're like, no, we don't want to have you administer any needles in arm, liability, no. But I think that relationship and trust that we built over time with them allowed them to open up their door. And so we set up shop at that library, and I think in that location we administer almost 10,000 shots. And I think that's really important work. Like the relationship that we built over time allow us to respond, especially during a pandemic. So I hear you when you want to talk about bringing community health workers to the library. It's an important space, But I also feel that their staff are very stretched thin because there's a lot of demand on that. So I'm always thinking about how can we alleviate some of your needs, for you instead of you having to do the work yourself, So.
If I could just add to that, we did do an environmental scan where 125 librarians from South Carolina responded. And I just want to highlight what you just said. It's many sometimes your teachers, the teachers can do this, this, and this, and this all in their room. Libraries are great, and other community centers are great as well-being hubs, but it's not that the librarians need to do that. Sometimes there can be some training, to be able to refer mental health first aid and to move on. But when we talk about it, it's not the librarians and the library taking it on themselves. It's creating the partnerships for the assistance and working together collaboratively. So thank you for lifting that up.
I want to thank our panelists for sharing your vision and your work. And I'm going to turn it over to Bruce Kellison.